Parathyroid hormone is produced by the chief cells of the parathyroid glands and is the primary regulator of serum calcium. Small changes in calcium trigger rapid changes in parathyroid secretion. Clinically, understanding parathyroid hormone physiology is essential in diagnosing hypercalcemia, hypocalcemia, chronic kidney disease, and related mineral disorders, as well as parathyroid adenomas. Calcium levels will directly regulate parathyroid hormone through the calcium sensing receptor on parathyroid cells. When calcium falls, parathyroid hormone secretion increases within seconds. When calcium rises, parathyroid hormone is suppressed. Vitamin D provides additional feedback by inhibiting parathyroid hormone gene expression. Clinically, disorders of calcium sensing, like familial hypocalciuric hypercalcemia, affect this regulatory loop. This graph demonstrates the inverse, highly sensitive relationship between serum calcium and parathyroid hormone. Even small drops in calcium cause a steep rise in parathyroid hormone, and this helps explain why patients with mild hypocalcemia often have significant levels of parathyroid hormone, elevated parathyroid hormone, and why normal PTH in the setting of hypocalcemia is inappropriate and indicates hypoparathyroidism. It's also important to note that this is plasma ionized calcium, which is different than the calcium level we get from ACMP, which can be falsely elevated with elevated albumin levels. Here we can see the intracellular signaling where low calcium increases cyclic AMP and triggers parathyroid release. Meanwhile, active vitamin D suppresses parathyroid transcription. Phosphate does not directly regulate PTH, but elevated phosphate will indirectly stimulate PTH by binding free calcium. And this is particularly important in chronic kidney disease, where phosphate retention can drive secondary hyperparathyroidism. The overall effect of parathyroid hormone is to increase serum calcium and decrease serum phosphate. PTH stimulates osteoclast activity within our bones. It does so indirectly, and it does so via osteoblast signaling. This increases renal calcium reabsorption, it decreases renal phosphate reabsorption, and increases the conversion of vitamin D to its active form. Clinically, this explains why hyperparathyroidism presents with hypercalcemia and hypophosphatemia. In primary hyperparathyroidism, typically it's caused by a parathyroid adenoma, but not always, but typically. Excess PTH leads to hypercalcemia through bone reabsorption, increased renal calcium retention, and increased intestinal calcium absorption. Patients may present with kidney stones, bone pain, abdominal discomfort, neuropsychiatric symptoms, or may be entirely asymptomatic with an incidental hypercalcemia level on a lab. In the converse or the inverse, hypoparathyroidism, PTH is low or ineffective, and this leads to hypocalcemia. The most common cause is an accidental removal or injury during thyroid or parathyroid surgery, as patients may present then with muscle cramping, paresthesias, tetany, or seizures. Because vitamin D activation becomes impaired, calcium levels can be difficult to correct without replacing both calcium and active vitamin D. This slide shows kind of the difference between PTH deficient hypoparathyroidism, where the gland cannot produce PTH, and PTH ineffective hypoparathyroidism, where PTH is produced but biologically inactive. This distinction matters because PTH levels will differ, low in the former, normal or high in the latter, and therefore treatment will differ based off on the underlying defect. In pseudo hypoparathyroidism, PTH is high, but the tissues are resistant to it due to defects in the GS alpha protein. Patients present with essentially the GAS subunit or the G alpha S subunit. Patients will present with hypocalcemia and hyperphosphatemia, similar to true hypoparathyroidism, but they'll have elevated PTH. They may also have resistance to TSH, glucagon, or even gonadotropins, and some forms present with characteristic physical features like short stature and even shortened metacarpals. So normal levels of parathyroid hormone range from 10 to 65. Levels do have a diurnal fluctuation with the highest levels around 2 a.m. And phosphate load can significantly elevate PTH, so fasting specimens are preferred. Hemolysis and elevated lipids can also interfere with testing. Therefore, interpreting PTH must always be done in conjunction with calcium and phosphate levels. So to evaluate for parathyroid hormone function testing issues in primary hyperparathyroidism, both calcium and PTH are elevated. In secondary hyperparathyroidism, we'll see typically from chronic kidney disease, PTH is high while calcium is either normal or low. And then tertiary hyperparathyroidism occurs when long-standing secondary disease leads to autonomous PTH secretion with both high PTH and high calcium. Understanding these patterns is essential to correctly form a diagnosis. And this is showing kind of a flow chart or a schematic of how you can interpret these results. Calcium always needs to be measured simultaneously since PTH release is tightly calcium driven. Also, keep in mind that certain medications like lithium or even thiazide diuretics can alter PTH or calcium levels. So, you always want to correlate lab results with clinical findings, renal function, and vitamin D status.